Good afternoon. I'd like to welcome everyone to the Monoclonal Antibody Update, Evidence, and Clinical Use webinar on December 7th, 2021. My name is Donald Moore and I'm with the Virginia Department of Health. I'll briefly cover a few administrative announcements before we begin. Attendees who joined by telephone, who have questions should email their questions to eprtraining@vdh.virginia.gov. Your feedback is requested. Please complete the SurveyMonkey survey provided in chat. It will also be emailed to all attendees as well. This webinar is being recorded and will be available online. Your speakers and moderator are as follows: Dr. Brooke Rosheim, Public Health Physician Specialist, COVID-19 Health Information Team, Virginia Department of Health; Nancy Pearlstein, Project Delivery Lead, Deloitte Consulting; and your moderator is Dr. Alexis Page, COVID-19 Pharmacy Coordinator, Office of Epidemiology, Virginia Department of Health. I'll now turn it over to Dr. Page.
Thank you so much for that introduction, and welcome everybody to this monoclonal antibody informational webinar. We have some really great speakers today, and I'd like to hand it over to Dr. Rosheim. Dr. Rosheim is leading our VDH COVID-19 therapeutics unit. So I am assisting him with the therapeutics rollout. So Dr. Rosheim has all of the clinical information regarding the therapeutics and the rollout. And so I'd like to hand it over to Dr. Rosheim so he can, jump right into the webinar. So thank you so much, Dr. Rosheim.
Okay, well, thank you. Thanks, Dr. Page. Good afternoon to everybody. I want to thank you for joining the webinar. Can everybody hear me okay?
Yes, I can.
Okay. So what I'm going to do is I'm going to go ahead and share my slides, and you'll be able to see those in just a second. And let me put this into the presenter mode. And can everybody see the slides in the large format?
Yes, I can.
Yes, Dr. Rosheim.
Okay. Well, let's go ahead and get started. So I'm joined today by Nancy Pearlstein, who is our colleague from Deloitte. And so I will do the first part of the webinar, and then Nancy will take over for a little bit, and then I'll jump back in, and we will then take questions at the end. Please feel free to ask questions. We certainly welcome your questions. So I'm going to go ahead and jump right in. So first of all, I just want to let everybody know that I do not have any financial or other conflict of interest to disclose regarding this talk. So first of all, let's talk about the monoclonal antibodies that we have available to us. So these are the three drugs, the three monoclonal antibodies that have FDA emergency use authorization for outpatient COVID-19 use. The first drug is casirivimab and imdevimab, and this combination of drugs is known as REGEN-COV. This is made by Regeneron, and what you can see is that I've highlighted the point is that REGEN-COV can be given by either IV infusion or by 4 subcutaneous injections of 2.5 cc's each. And that's actually going to be a thing that we're going to come back to, because that's kind of a useful thing with REGEN-COV. The second drug is sotrovimab. Sotrovimab is a single monoclonal antibody that's made by GlaxoSmithKline. And then the third drug we refer to as BAM-EDI, which stands for bamlanivimab in combination with etesevimab. So those are two monoclonal antibodies that are used together. Those are both Eli Lilly products. And so BAM-EDI is the combination of those two drugs. It bears mentioning a little bit more about BAM-EDI. For one thing I want to mention first of all, about all these three drugs is that they all are active against the Delta variant. But speaking about BAM-EDI, is that when BAM-EDI was tested against other variants like Beta and Gamma, BAM-EDI was not felt to be really effective against those two variants. And so what happened is in the pre-Delta days, you can see that at the end of June, BAM-EDI was put on hold by HHS and FDA. The reason for that was because we had other variants like Beta and Gamma that were circulating, and this was before Delta really took over the entire landscape. And so in early September, once Delta comes around and Delta takes over everything, then all the restrictions were lifted on BAM-EDI because this drug does have activity against Delta, and we want to use everything that we can against the Delta variant. And so now we're at a point where BAM-EDI is back in use, back in circulation. So how do monoclonal antibodies work? So in the first panel, panel A, you see the SARS-CoV virus. And the SARS-CoV virus is virtually identical, very similar to the SARS-CoV-2 virus. So what we see on the SARS-CoV virus is we see the spike protein that sits on the surface that everybody's familiar with. The spike protein binds to this ACE2 receptor, the angiotensin converting enzyme 2 receptor. This virus is then going to get internalized into the cell. The cell becomes infected. The virus takes over the cell. The virus replicates, and eventually what happens is the cell is going to release thousands upon thousands of virus particles that are going to go on to infect thousands more cells. And that's how the disease progresses. Well, if we look at panel B, now we've added this drug, S309, which is a monoclonal antibody. And what this monoclonal antibody does is it binds to this spike protein. And this monoclonal antibody achieves a couple of things. First of all, is that the spike protein can't really effectively bind to the receptor site that it's looking for because this monoclonal antibody is in the way. And if infection is blocked, if this virus can't get to the receptor, and if this virus can't get into the cell, then all of the downstream effects as far as replication of the virus in the cell, and in the cell, releasing thousands more virus particles out into the circulation, well, none of that can happen either. So what this does, this monoclonal antibody puts a block in this infection pathway. The second thing that this monoclonal antibody does is this is a flag to the immune system. So the immune system is constantly conducting surveillance of what's out there, and this is a flag to the person's immune system that says, come and destroy this thing that is coated with monoclonal antibodies. And then in the third panel, you just simply see the SARS-CoV-2 virus, which is virtually identical to the SARS-CoV virus, coated with monoclonal antibodies. The same thing, infection is blocked, and the virus is flagged for the immune system to come and destroy this. And so what monoclonal antibodies do is they directly neutralize the SARS-CoV-2 virus, and they are intended to prevent the progression of disease. And you can see on the molecular level how they prevent the progression of disease, and that translates into the clinical aspect of how they prevent disease at the clinical level. And sometimes you'll hear monoclonal antibodies referred to as blocking antibodies, and that's simply because of their role in blocking the spike protein from binding to its receptor site. So let's talk about the first use of monoclonal antibodies, and that is for the treatment of patients with mild to moderate COVID. We can use any of the three drugs. All three drugs have this emergency use authorization. Now, I do want to mention a point about REGEN-COV because this is worth mentioning. If you look at the package insert for REGEN-COV, it says, quote, for treatment, IV infusion is strongly recommended. Subcutaneous injection is an alternative route of administration when IV infusion is not feasible and would lead to a delay in treatment. So what I want to present you with is the idea that there is wiggle room here. The point being is that if you have a patient and it is going to take too long to get an IV in that patient, or if it's just not going to be possible to get an IV in that patient, you can go right to sub-Q REGEN-COV. The biggest issue here is getting the product into the patient as fast as possible. That is really the main goal. So if the clinician believes that giving it IV is going to, for REGEN-COV only, that if giving it IV is going to lead to a delay in treatment, that is fine. If you want to go ahead and give REGEN-COV subcutaneously. Giving REGEN-COV subcutaneously saves about 50% of time. So this is a screenshot of the FDA's website about, in this case, REGEN-COV. The link, the title of this slide is a link to the FDA website. The reason I put this in here is that this FDA website is really like the one-stop shopping of information about monoclonal antibodies. So in this case, I've given you the information about REGEN-COV. You know, the FDA website tells you the date that the first EUA was issued. You've got the most recent letter of authorization from FDA. You've got the authorized use. What is the indication for the drug? This thing right here, the healthcare provider fact sheet, this is the package insert for the drug. This is one of the most important documents that there is. And then you've got other documents. You know, you've got a fact sheet for patients, parents, and caregivers. Just so I will let you know that this is a little bit out of date because some of these have been updated. But the point that I wanted to convey is this is really the one-stop shopping for information about REGEN-COV. There's another similar on the same webpage. You're going to see a group of links with information for sotrovimab. You're going to see the same thing for BAM-EDI. So all of this stuff is right here for use, and it gives you pretty much everything that you're going to need to use the products. So let's talk a little bit more about the treatment of patients with mild to moderate COVID. So we've already said that we can use any of the three drugs. All three drugs have a treatment indication. So what specific things does our patient need to meet in order to get treated? The first thing is our patient is going to need to have a positive viral SARS-CoV-2 test. That can be a PCR test. That can be an antigen test. A point of care test is just fine. I will tell you anecdotally that I've heard about some monoclonal antibody administration sites that will only take a PCR test. Now, I will tell you in the package insert, that is not what it says. You can use a PCR test or an antigen test. Either one is fine. The second thing is we want to give the medication as soon as possible after the positive test. So really the idea is once we have that positive test, we want to literally pull out a checklist, and these checklists are available that literally go through point by point of does this patient qualify for monoclonal antibody therapy? If they do, we want to give it to them as soon as possible. So if we're at a site, if we're at a doctor's office that gives monoclonal antibodies, then we want to go ahead and get monoclonal antibodies into them that day if possible. If we are not at a site that gives monoclonal antibodies, then we want to refer that patient on to a site where they can get monoclonal antibodies. However, we are on a clock here. We have to give the drug within 10 days of symptom onset. Okay, but I will tell you that the goal is to get it as soon as possible. Another thing is our patient cannot be hospitalized because of COVID-19. Okay, so if our patient has COVID-19 and is sick enough to be hospitalized, that is going to take them out of the running to get monoclonal antibodies. Now, one question that has come up is what if our patient is in the hospital for something other than COVID-19 and they are just found to have COVID-19 as part of their evaluation. So what if a patient is in a car accident and they're not hospitalized because of COVID-19, but what happens is they get a COVID test when they're in the hospital and they're found to have mild to moderate COVID. Can that patient get monoclonal antibodies? The answer is yes, as long as they're not hospitalized because of COVID-19. So our patient has to be at least 12 years old, weigh at least 40 kilos, and they have to be at high risk for progression to severe COVID. Now, you see some stuff in red here, which means that this is important, and I'm going to come back to this in a second. The healthcare provider needs to review the EUA fact sheet, the package insert. The patient and caregiver have their own EUA fact sheet to review. Remember, these products are not FDA approved. They're under an FDA emergency use authorization. So we want to make sure that everybody's playing off the same page. The last thing before I come back to this is we need to administer the drug in a setting where the healthcare providers have direct access to medications to manage a severe allergic reaction and activate EMS. Now, this needs a little bit more discussion because I want to tell you what this is and also what this is not. What this is you need to be in a setting where you can start the initial management of somebody who is having a severe allergic reaction. So what this means is that you're going to need to have epinephrine, you're going to need to have Benadryl, you're going to need to have a stethoscope and a blood pressure cuff and the ability to call 911. That's what this means. What this does not mean is that you have to have a full hospital grade crash cart. So many of us are familiar with a hospital crash cart that has, 5 or 6 drawers full of drugs. It has intubation equipment and other airway equipment. You do not need to have all of that. All you need to have are the supplies to manage the initial management of a severe allergic reaction, and EMS is for the rest. That's what EMS is for. Okay. Now, I want to get back to this for a second because we have, new news that literally as of Friday, BAM-EDI can now be used regardless of a patient's age. This is a new thing. BAM-EDI got an expanded emergency use authorization. So for Regencov and Sotrovimab, those patients need to be at least 12 years old and weigh at least 40 kilos. For BAM-EDI, the patient can be of any age, literally down to a newborn. And the package insert has already been changed for BAM-EDI that it will show you the dosing for a newborn, and for pediatric patients that are younger than 12. So this is a new thing with BAM-EDI. So we talked about patients who are at high risk of progression to severe COVID. What does that mean? So what that means is that these people, basically, if they get COVID, they are more likely to have a severe case of it. And in the package inserts, in all 3 of them, you are going to see essentially a version of this table, okay, that I'm outlining with the mouse. And what this is these are common reasons that would put somebody into that high risk category. So for example, older age greater than or equal to 65, obesity or being overweight. I will tell you that when you look at studies of monoclonal antibodies for COVID-19, this is probably the #1 reason that people are in the high risk category is based on weight. Pregnancy is a risk factor. Chronic kidney disease is a risk factor, but this could be literally any kind of chronic disease. This could be chronic kidney disease, liver disease, lung disease, heart disease. You could substitute a lot of other things for right there. Diabetes. I'm not going to go through this whole list, but this list is what you'll see in the package insert. Now, this list is not exhaustive, okay? So this list is not the end all and be all of all things that will place somebody into that high risk category. And that's where this document comes in. This is a CDC website that goes into much greater detail about patients who are going to meet this criteria, this high risk criteria. The ones that have been put in the package insert are common things. There are a lot of other common things that you're going to find in here. And some of them may not even be medical things. For example, what if a person is homeless? That makes them that puts them into a vulnerable population category. I would feel very comfortable with them on this list as a high risk person. So this is a really good website to look at because it goes into much greater detail about who can end up in this high risk category. And so basically for the treatment of patients with mild to moderate COVID, that's really it. You're going to go through, make sure the patient meets the criteria. They're going to get their 1 dose of the medication of any of those 3 drugs, and that's it. They're done. That's all there is to it. And then hopefully that patient will get better. So that's the whole process. Well, now let's turn our attention to a second indication for outpatient monoclonal antibody use, and that is post-exposure prophylaxis against COVID-19. So these are people who have been exposed to somebody with COVID, and we want to try to prevent them from coming down with COVID in the first place. We've got 2 drugs that are available to us, Regencov and Bam-Edi. And notice with Bam-Edi, we've got it in red with an asterisk, which means there's something up with this. And as of December 3rd, Bam-Edi can now be used regardless of patient age. So the stuff that I'm going to talk about here in this little area here applies to Regencov and Bam-Edi. But the thing is, the patient 12 years of age and older, that does not apply to Bam-Edi. Bam-Edi can be used on people of any age. So remember we talked about Regencov for treatment of mild to moderate COVID, and the FDA said that they wanted us to give Regencov IV, and that if we couldn't give it IV, or if there was going to be a delay in giving it IV, then we could give it sub-Q. Now I want to show you some different language from the FDA when it comes to post-exposure prophylaxis. That can be given IV or sub-Q right from the get-go. There is no preference of one over the other. So for post-exposure prophylaxis, you can go right to sub-Q Regencov and save yourself a lot of time. Bam-Edi is only available by IV infusion, so that's the only way we can give that drug. So who is going to be eligible for post-exposure prophylaxis? So our patient is going to need to be 12 years of age and older if we're using Regencov. If we're using Bam-Edi, our patient can be any age. The patient is going to need to meet this high-risk criteria for progression to severe COVID we talked about on the previous slide. Our patient is going to be not fully vaccinated, or the patient is not expected to mount an adequate immune response to complete vaccination. And so what this means, this part is pretty simple, not fully vaccinated. This part, the FDA does not give us any definition. What this is basically someone who is immunocompromised or immunosuppressed. This is just a fancy way of saying it. And that is a pure clinician decision. FDA does not give you any specific guidelines to go by. If in the eyes of the clinician, this person is not going to mount an adequate immune response, that is good enough. Okay, and we have to have an exposure. So our patient is either exposed, and we know they're exposed to an individual with COVID-19, or our patient is at high risk of an exposure to somebody with COVID-19 because we're in some kind of a setting where we know that there are other people with COVID-19 in the same setting. For example, what if we have an outbreak in a nursing home? What if we have an outbreak in a prison or a jail? We may not know everybody who is exposed to everybody else, but what we do know is that people are at high risk because they're in a congregate setting and there are other people who have COVID in the same setting. So as long as we meet one of these two, in addition to these two, that gets us post-exposure prophylaxis. And it's the same thing. People get their 1 dose of either REGEN-COV or BAM-EDI, and then they're done. Did somebody have a question or something? I heard some background noise. Okay. So one of the things that I like to do is I like to provide some data about how did we get here? How did these drugs get to the point that they're at? So I do like to provide a little bit of data about studies that have been done. So this first study is a study with REGEN-COV. So in this study, we take people who have mild to moderate COVID. We give a bunch of them REGEN-COV. We give a bunch of them placebo. The meds are given by IV infusion. This is a treatment trial. The outcome that we're looking at is COVID-19 related hospitalization or death. So what do we see in this study? In 1% of people in the REGEN-COV group, they go on to either COVID-19 related hospitalization or death. In the placebo group, 3.2% of people go on to develop this outcome. This translates into a 70% relative risk reduction. That is a highly statistically significant finding, which means that it is very unlikely to be due to chance. So what this means, the translation is if you were in the REGEN-COV group, you were 70% less likely than if you were in the placebo group to go on to COVID-19 related hospitalization or death. What about BAM-EDI? So we do a similar study with BAM-EDI. We take a bunch of high-risk patients who are 12 and older with mild to moderate COVID. We give a bunch of them BAM-EDI. We give another group placebo. The outcome that we're looking at is COVID-19 related hospitalizations and deaths. What do we see? In the BAM-EDI group, we have 4 events. 4 people in the BAM-EDI group meet this outcome. In the placebo group, we have 15 events. 15 people meet this outcome. This translates into an 87% relative risk reduction. So if you were in the BAM-EDI group, you were 87% less likely than people in the placebo group to have a COVID-19 related hospitalization and death. What about sotrovimab? Well, sotrovimab, this is what is summarized in this COMET ICE trial. They took 583 adult outpatients with mild to moderate COVID. They gave them 1 dose of sotrovimab or they got placebo. The primary endpoint that they're looking at is progression of COVID-19. And this is defined as hospitalization for more than 24 hours or death from any cause. So what do we see in our group of patients? In the sotrovimab group, 1% of people go on to progress with COVID-19. In the placebo group, 7% of people go on to progression of COVID-19. This is an 86% relative risk reduction for this endpoint. So these are 3 studies looking at very relevant endpoints: hospitalization, death. Another endpoint that's been looked at is ER visits. And you're seeing significant reductions, 70 to 80+%. These studies are what got these drugs their emergency use authorizations and other studies. Now let's talk about, yes, so I saw a question. Yes, these slides will all be available to you after the presentation. So let's talk about post-exposure prophylaxis for a second. So let's talk REGEN-COV. So what they did with the REGEN-COV study is they took 1,500 people and they gave them either notice they gave them subcutaneous REGEN-COV. They didn't even go for IV REGEN-COV. They gave them subcutaneous REGEN-COV or placebo. Now, one of the things about this study that is pretty impressive is that these people are they are moving fast. I mean, this is really impressive. So remember, our patient is the contact. Our patient is the person who does not have COVID. So what they did in this study is they found the index patient. This is the person who does have COVID. And within 4 days, they found their contact who didn't have COVID And within 4 days, they got them enrolled into this trial. That's moving fast. That is really impressive. And the thing is, you already know what the outcome that they're looking at is simply who develops COVID. And that's exactly what they have here, said in just a lot more words. The primary efficacy endpoint is the percentage of participants in whom symptomatic, PCR-confirmed SARS-CoV-2 infection developed during a 28-day assessment period. And so what do we see in this study? We see that if you were in the REGEN-COV group, 1.5% of those people developed COVID. If you were in the placebo group, 7.8% developed COVID. This is an 81% risk reduction, relative risk reduction. This study is what got REGEN-COV its emergency use authorization to prevent COVID in people who had been exposed. So I want to let you know about a couple more developments before I turn it over to Nancy. So on September 9th, we have this 9th amendment to the HHS Prep Act that comes out. And what this does, the real main effect of this is this allows licensed pharmacists to order drugs that are subcutaneously given, IM, intramuscular, or oral COVID-19 therapeutics, and the pharmacist can order and administer these drugs by themselves. So a physician is not needed. Now, as of this point in time, the only drug that this is going to apply to in the monoclonal antibody category is the subcutaneous administration of REGEN-COV, because everything else is given IV. Sotrovimab is given IV, Bamedi is given IV, and the thing is, this order does not allow for IV therapy. So I can tell you that this is something that is under consideration by pharmacies and pharmacists in Virginia, and this provides more sites for monoclonal antibodies to be given. And also, when oral therapeutics become available, which they are not available now, this will provide an avenue for that as well. The most recent, another recent development was this was a pretty significant development, happened on September 13th, which is that HHS notified all the state and territorial health departments that all monoclonal antibody orders were now going to go through the state. The state is going to become the middleman. So before September 13th, if you were a monoclonal antibody site and you wanted the drugs, all you did was you went online, you submitted an online form, and then the drugs the next day showed up at your doorstep. Well, now what HHS has done is all the states, all those orders now come to us at the state level. And the state is the one who determines who gets what products and how much they get. Now, I can tell you, obviously, at the state level, our goal is to fulfill every order as much as we can. But, sometimes we do have to make some allowances in order to follow the rules of the program. So there are a number of rules. Right now, instead of a once weekly HHS allocation, we are now at an every 2 week allocation. So every 2 weeks, we get our allocation from HHS about how many doses Virginia is going to get. And that is what we have to work with. States and territories have been told that they are not supposed to exceed their 2 week allocation. The idea is you're not supposed to ask for more doses. Now, I will tell you there is a little bit of wiggle room in this one now because, it appears that in some cases you probably can get some additional product. We do not want anybody to stockpile monoclonal antibodies. So this applies to monoclonal antibody sites. We do not want people holding on to doses. So we want them to order only what they need for 2 weeks at a time. And I need to update these slides. Monoclonal antibodies that are not used in a 2 week cycle do not carry over to the next 2 week cycle. So Whatever we get from HHS needs to be used within that, needs to be allocated to our monoclonal antibody sites within that 2 weeks, and whatever we don't allocate is going to go back to the federal pool. The feds are keeping an eye on how much monoclonal antibodies are being used. The goal, which is an ambitious goal, is to use 70% of what we get every 2 weeks. Okay. The monoclonal antibody administration sites must report their usage to HHS. That is a mandatory part of the program. New sites, if you want to be a monoclonal antibody site, new sites must register with AmerisourceBergen, that's the medication distributor, and HHS before they can receive monoclonal antibodies. We can help with that process. So if you are a site that, if you want to become a monoclonal antibody site, please reach out to us, and you'll see some emails at the end. Please reach out to us because we can help you. So you don't need to know a lot of the stuff on this slide. The only point of this slide is that Virginia's allocation of monoclonal antibodies has been very good. The first week, the very first week, we only got 1,530 doses, and so we did have to cut some doses down in terms of what we allocated to the monoclonal antibody sites. But since then, you can look at the allocations that we've gotten from HHS, and they have been pretty good. Right now, we are in cycle 11. We have 3,126 doses for the current 2-week period, and that will end this Friday. This slide is a nuts and bolts slide. So if you want to know the fact sheets for the physician for all of the 3 drugs, so this is the package insert. This is a patient insert for the 3 drugs. We've got a link to monoclonal antibody infusion sites in Virginia. We've got information about reimbursement and coding. And then we have some various information about training for infusion. We've got an infusion toolkit. We've got some other resources. So these are just nuts and bolts kinds of things. Now, I want to mention for a second about the availability of monoclonal antibodies. One of the great things about monoclonal antibodies is that HHS has purchased all of them. So they've purchased Bam-Edi, they've purchased Regencov, and they've also purchased Sotrovimab. These drugs are available at no cost to monoclonal antibody administration sites. And in turn, those sites cannot charge the patient for those drugs. So the drugs are free to the patient. The patient may be charged sometimes for a clinic visit or the infusion service or injection service of giving the drug. At this point, I'm going to turn it over to Nancy Pearlstein, who's going to talk about Medicare reimbursement for monoclonal antibody administration. And so Nancy, it's all yours.
Thank you, Dr. Rosheim. Good afternoon, everyone. So as already mentioned by Dr. Rosheim, the monoclonal antibodies are free of charge. Our government has bought all 3 products up. However, they offer generous reimbursement from the federal government for the monoclonal antibodies. And the chart that you're viewing shows the 2 levels of reimbursement. Whichever monoclonal antibody is given, the reimbursement for giving the MAB in the pharmacy, in an infusion center, in a provider's office is $450. And again, that's for all 3, no matter which one you give, and no matter if it's the Regencov being given by sub-Q or IV administration, the reimbursement is the same. For your billing folks, to the left is the HCPCS code that's used. And there are different HCPCS codes for each of the MABs. However, as I said, the reimbursement is the same, but they will have to bill by specific HCPCS codes. If your pharmacy is not already a federal, does not bill the federal government, does not have the capability to do that billing, then you may not be eligible for quite some time. You would need to go through the application process, et cetera, et cetera. So you would just be administering perhaps the RegenCove and billing a commercial carrier if you had that ability. But to bill the federal government, you do need to be already a provider with the federal government. And likewise with the commercial organizations, but in most cases, pharmacies already have that relationship. The other very generous reimbursement is $750. And the differentiation between these two levels of reimbursement is if it's given in the patient's home. The higher reimbursement of $750 is for administration in the patient's home or what's considered their home. So it may not be a freestanding single home or a townhome or a condominium. It may be an assisted living facility where they permanently reside, or a skilled nursing facility where they permanently reside. And this is very unusual for the government. Oftentimes it would be considered double dipping to give this type of reimbursement while the patient or consumer is living in a facility that's already getting reimbursed. But for these monoclonal antibody administration, this $750 is offered in the facility where the patient resides. I would mention it's not if they're there for rehab, it's their permanent residence. And another reason that I wanted to point out why the reimbursement is generous is because it includes the 1 hour of observation time that Dr. Rosheim mentioned earlier. It's not just for preparing the IV solution or the 4 subcutaneous injections. It's the administration, including the 1 hour monitoring time after the medication has been given. And in your pharmacy or in a long-term care setting, you could potentially give these injections or infusions in the cases of the long-term care center and have the patients separated by 6 feet and then watch them together, have the observation time together. So you're actually maximizing the reimbursement by the monoclonal antibody administration procedures. And then the only other reimbursement that we wanted to discuss, and we have a reference on, is the HRSA reimbursement for non-insured. For those that have no insurance whatsoever, the federal HRSA program does offer reimbursement. And Dr. Rosheim is bringing up the slide that shows a reference and resource for that program that covers just about all COVID-19 related services. And I'll turn it back over to you, Dr. Rosheim, and happy to take any questions that come up. Thank you.
Okay, thanks, Nancy. So just a few more slides to go through, and then we'll open it up for questions. So as Nancy has already talked about, this is the HRSA uninsured program. A couple of things that I would point out about the HRSA uninsured program is that the patient must not have any health insurance. And the second thing is that COVID-19 must be the primary diagnosis. There cannot be any other primary diagnosis. So last few slides. These are some general monoclonal antibody resources. This is a link to the FDA website. This is a link here to our VDH monoclonal antibody website. Each of the drug companies, the 3 drug companies, has their own dedicated website to their own product. This website here, this Combat COVID HHS website, is really an excellent resource because it has, this is another one of these one-stop shopping websites. It has lots of information about monoclonal antibodies. It has information about how to set up a monoclonal antibody program, goes into a great deal of detail, which is very good. If you want to ask questions, obviously we encourage you to ask them now, but if you have questions that you want to ask later, here is my email address and here is Nancy's email address. We are happy to take your questions later on if you don't think of them but right now or if something pops up later. We've got plenty of references for you. So you've got one slide of references and a second slide of references, and then you've got the appendix, which we flip through, which shows you the Medicare and Medicaid payment allowances. And what I would call your attention to regarding Medicare and Medicaid payment allowances is this box right here. This is the current up-to-date information, and you can see these charts. Each chart goes through a specific product. So this is BAM-EDI, this is the Regencov, and this is sotrovimab, and as Nancy has already talked about, the reimbursement. So at this point, we're happy to take your questions, and I guess I will turn it back over to you, Alexis.
Thanks, Dr. Rossheim. That was a really great overview and had a lot of great information. And it looks like we already have a question in the chat. So besides allergies to monoclonal antibodies, who should not receive this treatment for COVID-19?
Well, the only thing in the package insert that you're going to see is that people who have, hypersensitivity to the product are not, should not receive the product. Now, another reason, is if you do not meet the emergency use authorization criteria. So for example, let's talk about post-exposure prophylaxis. What if we've got, remember, for post-exposure prophylaxis, we have to have a person who is either not fully vaccinated or someone who is not anticipated to mount an adequate immune response to complete vaccination. So sometimes a question will come up of a person who is fully vaccinated and a person who's got a normal immune system. Well, right there, that is going to take them out of the running of getting post-exposure prophylaxis because they do not meet the EUA criteria.
So it sounds like, the only prescribing of these medications or these products should be in line with the EUA.
Absolutely, yes. One thing to note is because these products are under emergency use authorization, there is no such thing as off-label prescribing. The prescribing has to be done in accordance with the FDA EUA. That is the way that these drugs are meant to be used.
I think that's something really great to mention. And you just brought up the monoclonal antibodies for pre-exposure prophylaxis. And so, in the COVID-19 pandemic, we've really been pushing vaccines and vaccine administration, everybody getting vaccinated. So what is the role of the COVID-19 vaccine now that we have monoclonal antibody treatment?
That's a great question, Alexis. And the role of the vaccine has not changed at all. Vaccination is the way to go. That is without question. Monoclonal antibodies, and if you look in the package inserts for the two drugs that can be used for post-exposure prophylaxis, so that would be BAM-EDI and Regencov, they state very clearly that those drugs are not meant to be used in lieu of vaccination. Vaccination, nothing changes with vaccination now that we have monoclonal antibodies. Remember, the whole goal is we don't even want to have to use these monoclonal antibodies. That's the whole thing. They're out there, but the thing is we don't want to use them because we want people to get their own immunity. Rather than getting immunity in a bottle of monoclonal antibodies, we want people to develop their own immunity from getting one of the vaccines that is either authorized or FDA approved. So great point that these drugs are not meant to be used as vaccine substitutes.
All right, so we have another question in the chat. So let's see, can you comment on some options for NH's partner? Is that New Hampshire for
nursing homes?
For nursing homes, thank you. To partner with a home health agency to provide monoclonal antibodies infusions for long-term care residents?
Sure. Yes, I'd be happy to. This is something that Dr. Simmers, that we have been really seeking out in a big way. We have reached out to the Virginia home care, Virginia home care agencies and their advocacy group. Yes, we would love it for nursing homes to partner with home health agencies to go into the nursing home, like Nancy was talking about, and give monoclonal antibodies. The issue that seems to be coming up is that there doesn't seem to be enough staffing in the home care companies to do their normal, the things that they would normally do as part of home care, and also to take on monoclonal antibodies as well.
I can
I'm going to let Nancy go into more because Nancy's has dealt with this more than I have.
Yeah, thanks, Dr. Rossheim. So the issue is that the home healthcare agencies have to open a case on all of these patients. One way around it, and they are not willing to do that for obvious reasons. They're short on manpower. It's very time consuming to open a home health service provider paperwork for each individual patient who's getting just monoclonal antibodies and probably doesn't need care after that. However, home health care that provides staffing, so the nursing homes that utilize external staffing to supplement their staff, they could bring in an RN to do this administration, and that would be the best way around it. But they're even short-staffed. As you know, there's a tremendous shortage. During the pandemic, people have left work, and so these home health care associations, service providers are very short-staffed. And those that do provide staffing to nursing homes are also short-staffed, but it's a little better situation asking for the long-term care facilities to bring on an agency RN for the purpose of administering monoclonal antibodies. But when we approached the home health care agencies as well as the long-term care facilities, neither felt they had the staff to do this, even when there was an outbreak. Fortunately, the incidence has gone down, but in preparation for, God forbid, if it goes up, we continue to pursue these avenues to get monoclonal antibodies into those that meet our criteria.
Yeah, I'm not sure. Can you hear me?
Yes.
Okay, sorry, I have a headphones on, but for me, actually, when I've done this, trying to sign up through AmerisourceBergen and things like, and looking at the complex ordering protocols, and now there's, emails going out about a new portal, and then we would only need maybe 1 or 2 doses at a time at my nursing home. So it just seems that it's not really set up to provide 1 or 2 doses to a provider, because I think that's the biggest hurdle. It's just that we're not an infusion center, right? But I don't know if you have any comments on that. It just seems that it's not set up for that, for such small doses, because they have ordering minimums, right?
What I would say is that for a nursing home, there are 2 avenues. The avenue that is, so a nursing home can either order monoclonal antibodies from the pharmacy that's from the institutional pharmacy that services that nursing home. That's probably the easiest way for a nursing facility to get monoclonal antibodies, is just to go to the pharmacy that you use, and get them from them, because we supply them. We have them on. We're the ones that supply them with monoclonal antibodies.
Yeah, we have a local pharmacy, so we're not with, Omnicare, CVS.
Okay.
So you were going to talk about your second option.
Well, the
So
second option is
your local pharmacy should still be getting them from VDH.
No, I can circle back, but it's more of a, but yeah, so they were not the last time I checked.
But the
Because I
thing
don't think
is,
they have the volume either.
the local pharmacy would need to sign up with us as essentially a pharmacy site. So if the pharmacy that you deal with is not signed up as a pharmacy site, like for instance Omnicare is and some of these bigger outfits, then they're not going to be on our list to distribute to. So there's 2 options. Number one is you could get your pharmacy to sign up as a site that can get monoclonal antibodies. The other option, which is the more cumbersome option, is you your nursing home can sign up as a monoclonal antibody administration site. A little bit more cumbersome. We can help you with the process, but that way, but the thing is, it's probably going to take longer for you to get the product because you'll be getting the product from AmerisourceBergen. You can probably get the product faster from your own pharmacy.
I'll reach out back to our pharmacy and see, you know what I mean? What their thoughts are. Thank
Okay.
you so much.
Sure.
Dr. Rossheim
Yeah.
and Nancy, we have one more question in the chat. So does receipt of the monoclonal antibodies for COVID affect receiving routine monoclonal antibody therapy for other conditions such as MS?
You know, that's a good question. I will tell you that there is nothing in the package insert for the monoclonal antibodies, the COVID monoclonal antibodies, that makes a mention of it interfering in getting any other type of monoclonal antibodies. That may be the type of question that a medical provider wants to reach out to the drug company's medical services to ask about, because it's a reasonable question. I will tell you that in the package insert, though, there's nothing mentioned about that.
Okay, good to know. Thanks, Dr. Rossheim. There is one more entry in the chat. So there is a shout out for VCU trial starting soon for patients who were fully vaccinated but potentially had an inadequate vaccine response. They'll be doing a pre-exposure prophylaxis soon with Regeneron. So if you have any patient referrals, that's a trial starting soon at VCU. Dr. Rossheim and Nancy, I do have one last question for us to kind of wrap up this webinar. So you both have been really integral in the planning stages and the rolling out of, the COVID therapeutics in Virginia. And so we've talked about what's kind of already on the ground, but what's kind of in the pipeline for the future?
Well, the pipeline is, we've got three things that are in the imminent pipeline. We've got molnupiravir, which is the Merck oral antiviral drug that has already made it through the FDA advisory committee process with a thumbs up. And so now that drug is with FDA. So we will, there is no timeline about if or when that drug will get its emergency use authorization. Another drug that's in the pipeline is the AstraZeneca monoclonal antibody, which is referred to as AZD7442. This is a drug that is with the FDA. And this drug, the company AstraZeneca has applied for the indication of pre-exposure prophylaxis. So this is a drug that would be used in a small number of patients who are immunocompromised or immunosuppressed or post-transplant, something like that, where these people would basically be looking to take a medication so that they do not come down with COVID in the first place. The third drug that is with the FDA is the Pfizer oral antiviral Paxlovid. This is a drug that the company has already submitted their application. There has not been any date set for an advisory committee meeting, which would be the usual route that this goes. So I, don't know when that's going to happen. This drug would be most likely used for the treatment of people with mild to moderate COVID, with basically the same indication as monoclonal antibodies to prevent people who are at high risk from going on to develop more severe disease. So that's three drugs. I am sure there are more drugs out there that are in clinical trials that are in the pipeline. Those are the three that people are looking at, people are most interested right now.
Great. Well, it'll be great to have even more options available for patients, hopefully in the near future. So we do ask that if you have the time, you can provide feedback. So you can complete the survey in the chat and give us any feedback on how we can improve and what you liked and what you didn't like. I want to thank everybody for taking an hour out of their busy day to be here and learn about monoclonal antibodies and the COVID-19 treatment. Thank you, Dr. Rossheim and Nancy, for being here today and going over this really in-depth presentation. So thank you, everybody. And with that,
Yes.
Thank you, Alexis.
and with
Yeah,
that,
thank you,
we'll go ahead and close out.
Thank you, Alexis. I want to thank everybody for participating, and please feel free to reach out to me or to Nancy later on if you have questions.
Thank you, everyone.